and its management. I am Dr. Vivek, resident at Institute of Vascular and Endovascular Sciences at Sir Gangaram Hospital, Delhi. So, compartment syndrome, it is defined as an increased pressure within the enclosed osteofacial space that reduces capillary perfusion below the level necessary for tissue viability. Basically, there is a pressure increase in particular compartment beyond the in the unyielding fascia, which leads to tissue compromise in the tissue viability. The underlying mechanism includes increased volume within space. There is decreased space for content and or combination of both. Then coming to types of compartment syndrome. There are two types of compartment syndrome. One is acute compartment syndrome, and the other is chronic compartment syndrome, which is also known as exertional compartment syndrome. Acute compartment syndrome is basically a medical emergency, and it is caused by a severe injury. It can lead to permanent muscle damage. Chronic compartment syndrome is not a medical emergency and most often caused by athletic exertions, wherein the particular activity leads to the pain in the particular compartment of that particular limb. Once you stop the activity, the pain will stop automatically. So local hemodynamics of a compartment syndrome, it is regardless of the etiology or anatomical location, it is a compartment syndrome. It is an increase in intracompartmental pressure within an unyielding facial envelope that impairs tissue perfusion. To understand this, we will go through the Poisson's law, wherein flow in the blood vessel is equal to the pi of fourth square of the radius with pressure gradient divided by 8 mu into the length of the blood vessel. Blood flow in the capillary is directly proportional with the radius of the capillary and the pressure gradient. The pressure gradient is between the precapillary arteriole and the postcapillary volume. So these two parameters, basically the radius and the pressure gradient, are the two variables which will change with the increase in pressure. Once there is increase in compartment pressure, it will lead to the increase in venous pressure and decrease in the arterial pressure, which will lead to capillary bed collapse, and this will eventually lead to the tissue perfusion. This tissue perfusion will lead to the increased capillary permeability, edema, and increase in the compartment pressure. And this cycle will go on and eventually lead to tissue death. So, several theories are explained are defined to explain the compartment pressures. Of these, critical closing pressure is one of the earliest theory. Other is absolute intracompartmental pressure threshold, and the third is dynamic intracompartmental pressure threshold, which is the most recent and most accurate prediction of a compartment to explain a compartment pressure syndrome. Critical closing pressures. This was proposed by Madsen, and it is the pressure above which capillaries collapse from transmural pressure and blood flow is arrested. Hartsock was the one who found that a pressure gradient between the intracompartmental pressure and mean arterial pressure of 25.5 plus minus 14 mmHg arrested capillary blood flow. This was eventually disproved though, because it did not consider take into consideration about pressure gradient, which is a critical determinant to assess compartment pressure. Absolute intracompartmental pressure threshold. This is another theory which tried to define the threshold intracranial compartment pressure. Hargens found that an absolute intracranial pressure of 30 mm of mercury for 8 hours universally produced muscle necrosis in normotensive dogs, whereas pressures less than 30 mm produced no muscle necrosis. This theory did not take into consideration again the dynamic intraarterial pressure due to the arterial blood flow, and this study basically was useful to get to know that tissues differed in their susceptibility even when the similar pressure is applied to the same tissue. The third and the most recent is the dynamic intracompartmental pressure threshold, wherein absolute pressure was ignored, which considered pressure gradient into account. Absolute pressure, which was ignored in the absolute pressure ignores the role of intra-arterial pressure, which was considered in this theory. Heppenstall found that healthy muscles in dog developed evidence of tissue ischemia when the difference between mean arterial pressure and intracompartmental pressure dropped below 30 mm of Hg. Injured muscle showed greater sensitivity to ischemia when mean arterial pressure and intracompartmental pressure was less than 40 mm of mercury. Dynamic pressure thresholds of less than 40 mm mercury thus prevented unnecessary fasciotomies in a number of patients with absolute, even though the absolute intracompartmental pressure in these were more than 30 mm of Hg. This dramatic increase in tissue injury and necrosis was noted, but was noted when the diastolic blood pressure and intracompartmental pressure difference was less than 10 mm Hg, 10 mm of mercury in dogs. This was noticed by Heckman. So these studies basically offered compelling evidence that a dynamic intracompartmental pressure threshold relative to the mean arterial pressure and diastolic pressure is more appropriate for selecting patients for fasciotomy. Coming to etiology, there are various vascular causes and non-vascular causes leading to compartment syndrome. Vascular causes would include ischemia, reperfusion, trauma, venous outflow, obstruction, or hemorrhage. Non-vascular causes would include fracture, crush injury, iatrogenic injury, and secondary compartment syndrome. Coming to ischemia reperfusion, it plays a central role in the pathogenesis of compartment syndrome due to acute ischemia and crush injury. Ischemia reperfusion increases compartment volume by causing muscle tissue injury, which leads to increased microvascular permeability with efflux of plasma proteins and progressive interstitial edema. With reperfusion, oxygen radical generation exacerbates microvascular permeability and resulting into interstitial edema. Orapin identified several risk factors for compartment syndrome after acute limb ischemia, which included inadequate blood flow from the distal arteries, high serum creatinine kinase levels, and positive fluid balance, and advanced stage and prolonged limb ischemia. Another cause is a trauma. Arterial and venous trauma will lead to compartmental syndromes in many of the cases. Occlusive arterial injuries result in distal ischemia, which initiates the ischemia reperfusion syndrome and again leads to compartment syndrome. Venous outflow injuries may compromise venous outflow and lead to compartment syndrome. Fasciotomy rates vary according to the type of vascular injury, and in isolated arterial injuries, fasciotomy was noted in 29.5% of patients, 15.2% of patients in isolated venous injuries, and combined arterial and venous injuries were required fasciotomy in 31.6% of patients. Injuries to the popliteal artery are notorious for a higher risk of compartment syndrome, which is 61%, and compared to the injuries above the knee, wherein 19% incidence of compartment syndrome was noted. Venous outflow obstruction, uncomplicated DVT often increases intracompartmental pressure, but often it doesn't lead to compartment syndrome. Only when there is extensive multi-level DVT with occlusion of venous collateral, such kind of venous outflow obstruction would be sufficient to produce a compartment syndrome. Here, basically, arterial venous pressure gradient is altered, capillary blood flow is impaired, and muscle cell is injured, exacerbating tissue edema. This cycle goes on, and eventually the post-capillary venous thrombose and venous gangrene would set in. Examples of this would include deep vein harvest for some arterial conduit wherein the venous outflow obstruction might lead to compartment syndrome, and sometimes even in ECMO, wherein 10.3% of patients who underwent ECMO had eventually landed up in acute compartment syndrome, even though the superficial veins were patent. In ECMO patients, we put in an arterial line, which again compromises the distal inflow, and again leads to an increase in chances of compartment syndrome. Another cause is hemorrhage. Rapid increase in compartment pressure is noted in hemorrhage in particular compartment. Thigh compartment syndrome is presenting symptom noted in rupture in popliteal artery aneurysm and postoperative hemorrhage after joint replacement surgery in an anticoagulated patient, often present with compartment syndrome in thigh. Coming to non-vascular etiologies, fracture, 1 to 29% of all fractures might land up in compartment syndrome. Tibial or forearm fractures are the most common orthopedic causes, wherein the surrounding muscle injuries and bleeding within the compartment increases the intracranial pressure, eventually leading to compartment syndrome. Anterior compartment of leg and flexor compartment of forearm are the compartments we particularly need to be watchful about. These are the most common compartments which will land up in compartment syndrome and eventually lead to muscle death. Compartment syndrome is more common in comminuted fractures wherein greater energy is absorbed in such injuries. Another cause is crush injuries. Example is crushing by equipment at industrial sites or large building due to earthquakes or due to blunt trauma during assault. Mechanism is basically direct muscle injury and ischemia reperfusion due to direct compartmental pressure, which leads to underlying muscle ischemia and subsequent reperfusion upon removal of the external compressive force. Large volume crystalloid resuscitation can exacerbate the increase in intracompartmental pressure as well. Coming to iatrogenic causes of compartment syndrome, extravasation of large volumes of fluid within a muscle compartment or extravasation of caustic medications such as contrast agent, inadvertent arterial injections. These basically lead to a collection of fluid in a particular compartment and eventually lead to compartment syndrome. Another example is hemorrhage related to arterial or venous punctures in coagulopathic or anticoagulated patients. Compression injuries associated with prolonged intraoperative immobilization as occurs in dorsal lithotomic position and cast immobilization from fractures. These kind of patients, wherein prolonged immobilization in particular position is noted, you often make sure that you change the position of patient if the duration of surgery is prolonged. Coming to secondary compartment syndrome, this term is applied in very specific occasions. For example, a trauma patient with any overt evidence of with no obvious overt evidence of extremity trauma, but lands up in acute compartment syndrome. This is basically due to trauma-induced systemic inflammatory response, which leads to eventually diffuse microvascular permeability. And also, we tend to resuscitate more in such kind of patient, and massive fluids would eventually lead to compartment syndrome, even though there is no obvious previous trauma. These kind of injuries are basically called secondary compartment syndrome. Coming to history and examination, you need to have a high index of suspicion when you are ruling out compartment syndrome. Pain that is disproportionate to the magnitude of injury is particular in any compartment wherein this is manifesting. Pain is typically not relieved in such kind of patients even by immobilization or reduction of fractures or response poorly to analgesic medications. Paresthesia in the distal extremity is an early symptom of ischemia of nerves traversing the muscle compartment in question. On examination of such patients, a tense swollen compartment with pain elicited by passive movement of the muscles is noted. On neurological examination, you need to rule out and document the sensory and motor response of the patient in that particular limb. In anterior compartment of the lower leg, wherein dysfunction of the deep peroneal nerve occurs due to compartment syndrome, leads to numbness at the first dorsal workspace of the foot or inability to extend the great toe, which might be noted early, and you might suspect compartment syndrome in such kind of patient. Compartment syndrome leads to loss of 2-point discrimination. Sensitivity of clinical findings is low and up to 13 to 19%, and negative predictive value is high, up to 97 to 98%. That is why Ulmer concluded that clinical features of compartment syndrome are more useful in their absence in excluding the diagnosis. Coming to measurement of compartment syndrome, this is usually not routinely not required to come to the diagnosis of compartment syndrome in most cases. If the cause of compartment syndrome is obvious and you can find passive movement of that particular muscle would lead to tenderness, pain, or neurologically significant findings are noted, then measuring ICPs, intracompartmental pressure is superfluous and risks delaying definitive treatment. Measurement of compartment pressure should be reserved for equivocal cases or unconscious patients or pediatric patients. Multiple equipments are available to measure the intracompartmental pressure. Simple manometer or a Vicks catheter and slip catheter, side-ported needles or fiber optic transducer are some of these examples. Each of these equipment has basically two components: a needle to access the compartment, and a pressure measurement system. The most commonly used is the arterial line manometer and handheld striker system. The most symptomatic or turgid compartment should be interrogated first, uh, which would be anterolateral compartment in the leg and the flexor compartment in the forearm. Pre-op intracompartmental pressure, mean arterial pressure, and diastolic pressure should be recorded so that if serial monitoring is required, that can be followed up depending on the baseline values. This is what a traditional compartment measurement setup looks like. You should make sure that the manometer and the limb are at the same level. There is a intracompartmental needle and a pressure measurement system with a stopwatch in between. What we do, the normal compartment pressure is 10 to 12 mm of Hg. These are some of the equipments which are available to measure the intracompartmental pressure: striker, handle system, and striker slit catheter, which are not commonly or routinely seen in our setup. There are a few unusual presentations for compartment syndromes which are noted in upper extremity, hand, thigh, foot, and buttock. In hand, this is due to usually crush injuries or fracture of the carpal bones. Sometimes in forearm due to direct blows, crush injuries or fracture. In thighs due to blunt trauma from road traffic accident or contusion or crush injuries. The anterior thigh compartment is the one which is most commonly involved. In gluteal, due to hypogastric artery ligation or embolization during various procedures such as aortic aneurysm repair or hip arthroplasty and prolonged compression during operative procedures. Such kind of patients might present with gluteal region compartment syndrome. This can lead to rhabdomyolysis and renal failure and sciatic nerve palsy. So what you need to do is, during prolonged surgery, you need to make sure that you change the position of the patient if required, if you're suspecting such kind of things, or you need to make sure there are soft paddings kept at particular vulnerable sites. How do you, there are various adjunctive measures for prevention of compartment syndrome, which would, the most common approach would be pharmacological therapy to blunt oxygen free radical formation during reperfusion of ischemic limb to minimize ischemic reperfusion injury. Various medicines have also shown promise to reduce the oxygen free radical formation and decrease the intracompartmental pressure in animal models. Though these are there are very few, limited, and only anecdotal reports. This includes mannitol, allopurinol, superoxide dismutase, deferoxamine, thromboxane A2, and melatonin. Mars came up with a protocol to treat impending compartment syndrome patients, wherein he said that first aid was needed to hypoxia cells. This is done by maintaining a normal pressure. This is done by maintaining the normal pressure, because hypotension would eventually lead to perfusion, decrease in the perfusion pressure, removing any constricting bandages at the affected limb, maintaining the limb at the heart level with no elevation to avoid reducing the arteriovenous pressure gradient, and supplemental oxygen is provided to optimize oxygen saturation. Another thing is prevention of systemic sequelae. Myonecrosis is most prominently noted, which would in compartment syndrome, which would liberate intracellular potassium phosphate, myoglobin, or creatine phosphokinase. To prevent this, various systemic sequelae are aimed to, so that the further complications related to the electrolyte imbalance and myoglobinuria can be treated. This includes treating myoglobinuria and hyperkalemia. Significant myonecrosis in compartment syndrome would lead to crush injury. Typically in crush injury patients would lead to hyperkalemia, which might eventually lead into cardiac arrest. Aggressive pharmacological interventions or even hemodialysis or continuous hemofiltration might be required in such cases. Myoglobinuria is another thing wherein nephrotoxic effects are induced because of the renal vasoconstriction, tubular cast formation, or direct heme protein induced cytotoxicity. Heme proteins have maximum nephrotoxicity in hypovolemic and aciduria conditions. The management in to treat myoglobinuria in compartment syndrome would be to give aggressive crystalloids, forced diuresis with mannitol, and alkalinization of the urine with bicarbonates. Recommendations for the management of myoglobinuria include hydration with the goal urinary pH of greater than 6.5 and to maintain urine output of more than 100 ml per hour. Myoglobin has a large molecular weight of 17,000 daltons, so it is poorly cleared by the conventional dialysis membrane. So hemodialysis is not a useful adjunct in myoglobinuria. So how do you decide when to go ahead with fasciotomy? This is dictated upon the clinical grounds and intracompartmental pressure measurements. A clinical criteria would include a turgid compartment with either of the two criteria, that is pain with passive motion of muscle groups traversing that compartment, or a positive finding of neurological finding limited to that particular compartment. This is enough to go ahead with fasciotomy in any particular patient. But these criteria are not usually required, and any neurological finding referable to a tense compartment is an absolute indication for urgent fasciotomy because nerve injury is ongoing in such patients. Then there are few equivocal categories wherein presence of tense compartment alone is noted, but there are no other signs, for which options would be to do a serial monitoring or to do a fasciotomy. Whenever you do serial monitoring for such kind of legs, you need to make sure that the one who is doing monitoring is an experienced surgeon and he has dealt with such kind of scenarios previously, and the intracompartmental pressure measurements in such a scenario would be helpful in making a decision of fasciotomy. Now, patients who are obstructed or require other operations are poor candidates for serial examination, making fasciotomy the best option. An important consideration is likely evolution of muscle swelling over the next several hours. In equivocal cases, in addition to muscle swelling, prophylactic fasciotomy may be prudent. There are few scenarios in which prophylactic fasciotomy may be reasonable, which would include acute ischemia of more than 6 hours. If there are inadequate collaterals and combined arterial and venous traumatic injuries. Intracompartmental pressure measurements, threshold ICP, intracompartmental pressure remains controversial. The data favors the use of dynamic intracompartmental pressure thresholds related to mean arterial pressure or diastolic pressures. And fasciotomy is warranted if the difference between the intracompartmental and mean arterial pressure falls to less than 40 mmHg, and difference between the intracompartmental pressure and diastolic pressure is less than 10 mm of mercury. So to summarize, the absolute indications for fasciotomy would be tense compartment plus either a pain with passive movement of the muscles of that compartment, or paresis of paresthesia referable to the same compartment. Other is tense compartment in a patient who cannot be examined serially due to obstruction or need for other operations. Another would be ICP minus mean blood pressure, which is less than 40 mm, and ICP minus diastolic blood pressure if it is less than 10 mm of mercury. Then potential indications, acute ischemia of more than 6 hours with very few collaterals, combined arterial and venous traumatic injuries, phlegmasia cerulare dolens, tense compartment after crush injury, and tense compartment after fracture. Coming to contraindications of fasciotomy. Fasciotomy is contraindicated when the extremity is non-viable due to extensive traumatic or ischemic injury. Crush injuries in particular may result in life-threatening complications from reperfusion because of the magnitude of the electrolyte shifts. Technique of fasciotomy. Fasciotomy is the only known treatment for acute compartment syndrome. Adequate fasciotomy is critical for complete decompression. Poor technique of fasciotomy might lead to incomplete decompression or injury to the adjacent structures. The timetable, the nerve damage, depending on the dynamic IC intracompartmental pressure, would be starting of neuropraxia at the end of 1 hour, and after more than 6 hours of development of compartment syndrome, there would be tissue necrosis and impaired limb function. But obviously, these are dependent on the dynamic intracompartmental pressure. Coming to basic anatomy of the lower leg, there are 4 compartments in the lower leg: anterior, lateral, the superficial posterior, and the deep posterior. For full decompression of all compartments of a lower leg, you need a fasciotomy of around 12 to 20 centimeter in length. Limited incisions are indicated when you expect the muscle swelling to be minimal, wherein you don't expect that the timeline for intervention has been very small. Unfortunately, it is difficult to predict how much the swelling of muscles would be, and the swelling might gradually evolve. So it is difficult to predict whether you need to give a limited incision or a long incision. But depending on how the intraoperative findings are, you can proceed. Most commonly, nerve injured during fasciotomy of the lower leg is the superficial peroneal nerve. This is usually found at the upper end of the fibula head, and the common peroneal nerve branches into superficial and deep peroneal nerve at this particular point at the proximal fibular head. So you need to be cautious of this. There are 2 techniques to do fasciotomy of lower leg. One is the double incision technique, and another is the single incision technique. In the 2 incision technique is relatively simple and allows rapid decompression of all the 4 compartments. The first compartment, the first incision includes a longitudinal incision over the lateral aspect of the lower leg between the fibular shaft and the crest of the tibia. It is preferable to give this incision directly over the intermuscular septum between the anterior and the lateral compartment, approximately 4 centimeter lateral to the tibial crest. Then flaps are raised underneath, and another facial, 2 facial incisions are given over the anterior toward the release of anterior compartment, and another facial incision for the release of lateral compartment. You have to make sure that the Caesar should be pointing upwards, so that to avoid inadvertent injury to the common common peroneal nerve or superficial or deep peroneal nerve near the fibular head. That is why you always extend the incision at this site away from the fibula head, around 4 to 5 centimeter away from the fibula head. The second incision is usually placed 1 to 2 centimeters posterior to the tibia, and this is where the saphenous nerve and the saphenous vein would be most commonly noted. You have to protect them during this incision. The superficial posterior compartment is decompressed via the longitudinal incision over the gastrocnemius fascia, and the deep posterior compartment is decompressed by dividing the attachments of the soleus muscle to the tibia and exposing the fascia overlying the tibialis posterior and flexor muscles of the foot. You should be cautious about injuring the posterior tibial artery during this decompression. Single incision technique of fasciotomy is relatively tedious, with potential injury to peroneal artery and nerve. Here, a lateral incision is given over the fibula from the fibular neck to 3 to 4 centimeters above the lateral malleolus. Then subcutaneous flaps are developed to access the anterior and lateral compartment, as in the double incision technique. The posterior flap is used to develop the access to the superficial posterior compartment, and the interval between the lateral and superficial posterior compartment is exposed. The peroneal vessels are then displaced posteriorly to avoid injury to the structures during the subperiosteal dissection. The facial attachment of the muscle to the fibula is incised to open the deep posterior compartment. Most surgeons now favor double incision technique. Earlier, fibulectomy was also done in the single incision technique, but this is not routinely done nowadays. Coming to thigh, there are 3 compartments mainly in thigh: anterior, posterior, and medial compartment. Femoral nerve, anterior compartment is associated with the femoral nerve, posterior is with sciatic nerve, and medial compartment is supplied by the obturator nerve. In most of the cases, a single incision is given lateral between and decompression of the anterior and posterior compartment is done. Medial compartment usually does not need decompression. The incision is usually placed from the intertrochanteric line to the lateral epicondyle. Anterior compartment is opened by incising the fasciolata, and the vastus latalis is retracted medially to expose the lateral intermuscular septum, which is incised over the length of the skin incision to release the posterior compartment. Medial compartment release is, if required, then a separate incision has to be placed over the adductor group of muscles medially. Buttocks has basically three major muscles, and each has their own fascial compartment. There is no universally accepted standard incision for buttock fasciotomy. Longitudinal incision is placed, and some recommend neurolysis of the sciatic nerve to prevent tension on the nerve from inflammatory adhesions postoperatively. Foot, there is a variability as to the number of compartments which are associated with foot. The most frequently named compartments in foot are medial compartment, lateral compartment, then calcaneal compartment, and additional compartment corresponding to the interosseous muscles. Decompression of foot is required infrequently and most commonly associated with crush injuries. Two longitudinal incisions are placed on dorsum of the foot for decompression of the foot. The first incision is placed medial to the second metatarsal, and the other incision can be placed over the lateral margin of the fourth metatarsal bone. To decompress the calcanean compartment in this patient, you might have to give another separate incision. Care must be taken to avoid medial and lateral plantar neurovascular bundles that traverse the longitudinal axis of the foot. Coming to upper limb fasciotomies, most frequent site of compartment syndrome in the upper extremity is volar compartment, which involves the flexor, superficial, and deep area. Then lateral is not commonly seen and extends the compartment. Volar fasciotomy, or it is also known as Henry fasciotomy, wherein a curvilinear incision begins from the proximal to the antecubital fossa, medial to the biceps tendon, and crosses the antecubital crease, extending towards the radial side of the forearm, and it extends distally along the medial border of the brachioradialis muscle. It can be extended over the carpal tunnel along the thenar crease as well. If hand decompress, if the dorsal intracompartmental pressure is elevated, a long incision from lateral epicondyle of wrist can also be placed to perform a fasciotomy between the extensor carpi radialis brevis and extensor digitorum communis. Carpal tunnel release is controversial and may not be of benefit in isolated forearm compartment syndromes. In hand, hand is one of the not common presentation for compartment syndrome, and there are 10 compartments in hand, namely the hypothenar, thenar, adductor pollicis compartment, and 4 dorsal intraossei compartment and 3 volar intraossei compartments. Because of such a 10 compartments in the hand, it complicates decision making in performing fasciotomy in hand. And choice of fasciotomy should be tailored to according to the symptoms and to the particular compartment which needs treatment. All patients should have carpal tunnel release in hand compartment syndrome, and most will require 1 or 2 dorsal intraossei fasciotomy as well. Many patients will also require thenar or hypothenar fasciotomy. Coming to fasciotomy wound management, fasciotomy, though it may solve the problem of increased intracompartmental pressure, but resulting wounds may be a source of considerable short and long-term morbidity. The goal in wound care is basically to prevent any further muscle injury or necrosis until muscle swelling subsides considerably to permit any further closure of the wound. Saline dressing along with close watch is done along with debridement as and when needed. Once wound swelling has subsided and viability is ensured, focus shifts to the wound closure, and wound closure can be fasciotomy wound closure can be attained through a variety of approaches in such patients. Delayed primary closure, closure by secondary intention, gradual derma apposition, Skin grafting, myocutaneous flap coverage are majority of the approaches which can be used. Also, VAC therapy can be used in fasciotomy for fasciotomy wound coverage. Early outcomes, mortality rate for patients undergoing calf fasciotomy ranges from 11% to 15%. Major amputations are required in 5 to 21% of the limbs despite fasciotomy. Wound complications occur in 4% to 38% of the patients. Wound complications are most frequent if fasciotomy is delayed more than 6 hours and compared with earlier fasciotomies. Renal failure is a rare complication of compartment syndrome when there is considerable myonecrosis noted. Uh, Neurological deficit occur in 7% to 36% of limbs and are most frequent early complications following a forearm fasciotomy. Late outcomes are determined by the functional status of the patient at hospital discharge. Fitzgerald and colleague noted at late follow-up that 77 of fasciotomy sites were associated with impaired sensation at the margins of the wound. 7% had tethered tendons and 13% had recurrent ulcerations at the fasciotomy site. Bermudez and colleague noted that significant proportion of patients had clinical evidence of chronic venous insufficiency after lower leg fasciotomy due to impaired calf muscle pump function. A small subset, that 7.5% of the patient, might require late amputation between 30 days or 1 year. What happens now if you have missed the compartment syndrome? It increases the risk of neurological deficit, amputation, and renal failure. Sheridan and colleagues found that overall complication rates increased dramatically if fasciotomy was delayed more than 12 hours compared to earlier fasciotomies, wherein only 4.5% patients uh, showed complications. Nearly half of the patients with delayed fasciotomies required amputation, and 92% had a significant neuropathy. Delay of fasciotomy for more than 36 hours almost invariably results in amputation. After 3 to 4 days, compartment syndrome decompression is not indicated since the rate of infection and muscle necrosis is very high. Classically, what you find after a missed compartment syndrome is Volkmann contracture, wherein the ischemia of the muscle and nerve tissue is replaced by the fibrosis, leading to compartment getting firm and contracted and gradually dysfunctional. Adjacent joints become stiff and immobile, and treatment of this includes contracture and joint capsule release. Coming to chronic exertional compartment syndrome, this group is a syndrome of exercise-induced pain and tightness that usually affect the muscle of the lower leg, especially the anterior and lateral compartment due to increased intracompartmental pressure and transient muscle ischemia. This is typically noted in young and athletic patients who are runner between the age bracket of 20 to 30-year-old. The syndrome is characterized by pain beginning 20 to 30 minutes after the onset of exercise, which ablates with 15 to 30 minutes of rest. Paresthesia and muscle dysfunction often occur in the distribution of peripheral nerves traversing the compartment, and symptoms might be bilateral in 82% of the cases. On physical examination of this patient, you often find tenderness of the affected muscle compartment. Differential diagnosis for chronic exertional syndrome, compartment syndrome includes facial hernia, medial tibial syndrome, and claudication due to popliteal entrapment syndrome. Although MRI and other tests may rule out other causes of leg pain, measurement of intracompartment pressure is required to secure diagnosis of chronic exertional compartment syndrome. Pedowitz and colleague established pressure criteria for the diagnosis, and this includes resting intracompartmental pressure of more than 15 mm mercury, intracompartmental pressure of more than 30 mm mercury after 1 to 2 minutes after completion of exercise, and intracompartmental pressure of more than 20 mm mercury after 5 minutes of completion of exercise. One or more of these criteria is sufficient for the diagnosis with characteristic symptoms that are reproducible on exercise. Fasciotomy and fasciectomy have been both proposed for the decompression of symptomatic chronic exertional compartment syndrome. Treatment usually includes avoidance or surgical decompression. Usually, these patients are athletes, though there is poor acceptance for avoidance of exercise, so fasciotomy is the treatment of choice. Fasciectomy for this treatment has also been suggested. So, subcutaneous fasciotomy in chronic exertional syndrome is different from what we typically do. Here, 2 to 4 centimeter transverse skin incisions are placed over the usual lateral site of incision. These are transverse incision, skin incisions. Then 2 longitudinal facial incisions are placed over the lateral and the anterior compartment from these transverse incisions. Fasciectomy, a single longitudinal skin incision is placed over the intermuscular septum between the anterior and lateral compartment, what we usually do. And through this single incision, facial incisions are performed over the anterior and lateral compartment, and this segment of fascia is excised. In a review of treatment for 796 patients with chronic exertional syndrome, Turnipseed advised fasciectomy as the treatment of choice in most cases. Long-term results appear promising in case series. We describe significant reduction in pain at 2 years following anterior compartment fasciotomy in 83% of the subjects. Thank you.